This is a grossing tutorial video on how to process a portion of colon for diverticulitis. We've got the segment of sigmoid colon here. We've got two annular-shaped portions of mucosal tissue here, which we call anastomotic mucosal rings or donuts, these two specimens here. We've got portions of epiploic fat that came separate. Let's go ahead and zoom in on these donuts real quick, or like I said, anastomotic mucosal rings. As you can see, this one right here at the deep aspect has a portion of blue suture material. So I'm going to go ahead and ink this donut blue. I'm going to leave this one uninked. These are sometimes considered the true mucosal margins. We've got our fat here, of course. There's actually an adhesion right here. Let's go to the main specimen. So here's the sigmoid. It's been partially opened here. At this end, we have a stapled mucosal margin here. At this opposite end, like I said, which has been previously opened, we've got an open margin here. Now at the midline here, there is a very thickened area of serosa right here. There's a bunch of adhesions. I don't see an obvious stricture in this area, but there's definitely some thickened serosal adhesions here. And there are also some adhesions here, and also another area of thickened serosa here, right at the interface between, it looks like the radial margin, or the mesenteric radial margin here. So, like I said, there's a bunch of serosal adhesions. I don't see any obvious exudate in this area, which you do sometimes see with diverticulitis. Don't see any exudate in this area also. So what we're going to do is we're going to go ahead and ink one margin a different color than blue, because we're going to use blue for the anastomotic mucosal ring or donut. So we're going to use maybe black here for this stapled mucosal margin. The open margin here, we're going to not use any ink. So let's come back to the specimen after I've inked it. So we're coming back to the specimen, and I've inked it. So I've done the distal stapled mucosal margin black. I've done the areas of thickened serosal adhesions and thickened serosa green here and green here. I've inked the anastomotic mucosal ring or the donut blue. Now, before I start sectioning the specimen, when examining the external surface, we talked about adhesions, which there are some. We talked about exudate, which there is no obvious exudate. But if you do see exudate, it's often a sign that there is a perforation going on with the specimen. Also, in this case, with the extensive serosal adhesions, you got to make sure you check the external surface very well for any structures that aren't supposed to be there, like fallopian tubes or ureter or bladder, a portion of bladder. Sometimes there's fistula tracts, those kind of things. So make sure you examine the outside very well and before you start sectioning. So what I'm going to do is I'm going to submit this entire mucosal ring here, this entire mucosal ring here in separate cassettes. Some places will have you do the mucosal margins from the sigmoid segment as well. I'm not going to submit the mucosal margins here or here. So let's go ahead and open up this other mucosal margin that's got a staple line. And what I like to do is grab the staple line right underneath it with these forceps. There's teeth right here. And what I like to do is grab it there and cut right immediately subjacent to it. Sometimes the staple line will pop off like that. So I'm just going to cut right immediately subjacent to it. Some people will cut a little bit extra underneath it. I like to do this because if there's a lesion right at the staple line, I'm going to see it. You probably would see it if you cut extra mucosa underneath the staple line as well, but there's a chance you could cut through it. So I like to cut the staple line as close as I can to the mucosal surface. So I've done that. I usually do save these staple lines. Okay. Now we're going to open it. Usually you do anti-mesenteric. What I'm going to do is I'm going to place my finger inside the sigmoid segment and feel for any mass lesions or areas of ulceration before I start cutting. So I'm cutting through the serosal surface now. Now I'm going to go ahead and go around this area of thickened serosal adhesions if I possibly can. Also, it's important to note, if you look at these scissors, there's a pointy end and there's a rounded end. I like to use the rounded end to go into the lumen of the sigmoid colon first. And so what I'll do is I'll stick the rounded part in first, and that prevents it from kind of getting stuck inside the colon. Once again, I'm putting my finger into the lumen of the colon, searching for any kind of mass lesion or area of ulceration. Cutting along the serosal surface. I'm going to continue my line right here with where it was previously opened. Okay? So the first thing you want to do is look within the lumen for any foreign material. And I'm not seeing anything that looks foreign. There's no bones, or, I mean, sometimes you can get foreign material where someone has a diverticulitis case and they get a perforation, and it could be from something they ate, or it could be just long-term or long-standing diverticulitis. So the mucosa is very edematous. It's very crowded. It's thickened. There's focal areas of congestion. And then down here, as I palpate, run my hand across here, there's some areas of granular nodular mucosa. And these are either sessile polyps or they're pseudopolyps, which you can sometimes see with inflammatory processes. So I've examined this. There's no areas of ulceration. There's no tumor. There's pseudopolyps, pseudopolyps versus possible true sessile polyps. Okay, so I'm going to rinse this out, and then we'll come back to this here in a second. So I've cleaned out the bowel with some water. And now what I'm going to do is I'm going to section or bread loaf the specimen from one end to the opposite end. I've already taken the anastomotic donuts or the rings and submitted those. I still have a fat here that I need to submit some representative from. So once again, I'm going to start sectioning it from one end to the other, probably at about 1 centimeter, actually 0.5 to 1.0 cm, just to make sure I don't miss anything. And also sometimes if there is a perforation or a tract, you can miss it if you've gone too thick on your slices. And I do try to keep the specimen intact as much as possible as I'm sectioning. And like I said, I'm just going to section it perpendicular to the long axis, fairly thin. And especially what you can do is you can do about 1 centimeter intervals until you get to the area of adhesions, because that's most likely going to be the spot where there might be a perforation or a tract of some sort. So I'm just continuing the sectioning through here. You can certainly clean your blade between slices if you want. So I'll come back to this in a second. Let me finish sectioning it. Okay, so I've sectioned the specimen perpendicular to the long axis. I've kept the specimen intact. So here is an example of a complicated diverticulum right here. In fact, let me zoom in a little bit more. So once again, here's an example. Here's the mucosal surface here, and here is the diverticulum here, which has got some congestion and stuff around it, so I'm sure this one is inflamed histologically. So once again, there's a divertic. Now, if we go over to this end of the specimen, as you will recall, I had those pseudopolyps versus true polyps. So what I did as I was sectioning through the specimen and bread loafing it, when I got to this area, I made a much thicker section to preserve these pseudopolyps versus true polyps. So here's one right here. Here's one right here. Here's one right here. So I'm going to submit those in one block, okay? Now, the remainder of the specimen has very extensive fibrosis and diverticulitis. So as I'm looking through these slices, there's a conspicuous lymph node here, okay? The other half is here. Let's go. As I get closer to the areas of adhesions, I do notice that there's a lot more going on. There's a lot of more extensive fibrosis, and possibly even a perforation site. But it's hard to tell. There we go. That's a little better. So, if you look in this area here, there's actually a tick, a very deep one right here. This is not a lymph node right here. This is actually a tick right here. And then all of this is extensive fibrosis, and there's some yellow discoloration here, 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 and also up here. This is an area of fat necrosis. I'm not sure if you can grossly appreciate that or not through the video. So we're going to continue looking through here. Like I said, this person probably had some long-standing diverticulitis for quite some time. Here's a tick here. This is either an abscess cavity forming or a sinus tract. You can often see these with people that have extensive diverticulitis. They can have sinus tracts, abscess cavities, of course, peritonitis. So once again, extensive fibrosis through here. There's an area, a little focal area right here, actually where the adhesion is. Right here, we've got an area of fat necrosis right here. So as I continue on, now this area right here, I'm probably going to definitely sample. There's a real hemorrhagic, kind of a variegated area right here. So I'm probably going to make sure I sample this area. This may be a past perforation or sinus tract, or just tract in general that has traveled through here. This is also where the additional area of thickened serosal adhesions are at. Once again, extensive fibrosis. There's a conspicuous lymph node here. So that's what's going on with this case. I'll probably submit probably 4 blocks worth of complicated diverticula, and I'll include in those blocks any areas that are possible areas containing abscess cavity or sinus tract or fat necrosis. And then I'll sample, of course, the 2 separate portions of epiploic fat